one thing, if you do need to leave early, you still have an evaluation and haven't signed it yet. Please do so before you go.
Thank you very much. Thanks for having me today. So I'm going to tell you about what we finally refer to on the study team as the OB immunization trial, but really the theme for today is making a sandwich. Since it was over lunchtime, I thought that would be appropriate. And I was looking for a really cool picture of a sandwich, and I pulled this one out, and then as I was looking at it today, I was like, that's like broccoli and red peppers and mozzarella cheese. I personally have never had a sandwich anywhere close to that, but I thought it looked cool as a picture, and then I kind of saw it later and I was like, that probably wasn't the best option. Sorry, what? Oh yeah, yeah, it's probably very healthy. So today I have two objectives for our talk. I want to tell you an example of how we use what I like to call a sandwich approach. You can tell I'm not a methodologist. For mixed method research, and I'm going to present the trial results to you, but really the main focus of my talk I'm hoping to convey today is kind of how we use mixed methods to inform the various stages of the trial, not so much the trial results itself. So this is a slide taken from Megan's talk. Did anybody miss the first talk? Okay, yeah, so that's what I figured. So this was a slide taken from her talk about just to kind of overview of what's the difference between mixed methods versus multi-methods. So you can see that both use a variety of different methodologic types, usually both qualitative and quantitative. But the key is that with mixed methods, you really are talking about integrating the two approaches so that one informs the other, so that there's a sort of a synergy between the two. And I hope that the project that I present to you today will provide an example of that. So when do you use mixed methods? Well, this was definitely the case in a lot of my work as well as the study I'm going to present today. It's really when you want to gain multiple perspectives to try to enhance the meaning of your results or to understand the context in which your results are happening from your study, especially if it's a fairly complicated problem that you're trying to address, and I would argue that immunization delivery probably is fairly complex. It also can help to triangulate results. So sometimes you get results from your clinical trial that maybe you're not quite sure, are they real or not? And if you have another data source, for example, a qualitative data source, can really help you feel secure that the interesting findings that you're seeing aren't just a result of some spurious random thing happening, but actually are real. And I think what's really been helpful for me is I do a lot of pragmatic clinical trials, and so mixed methods are extremely helpful when you're studying people in their own settings as opposed to a very controlled lab environment. Again, this is from Megan's talk. So I like to think the sandwich analogy, and so she explained in her introductory lecture about the different types of mixed methods research. And the project I'm going to talk to you about today is actually a combination of two different ways of doing mixed methods. So the first one is explanatory sequential, bring qualitative data, and you use that information to inform your quantitative data collection and or analysis, and together the results are interpreted. The second format is explanatory sequential, where you take your quantitative data and then you do a qualitative assessment surrounding that to help you understand the context of your quantitative data. So putting this back into the sandwich analogy, I'm going to talk to you about some bread, which is qualitative, and then we're going to go to peanut butter, which is the quantitative, and then imagine this is one long diagram, so here we are with the peanut butter again, and then we're going to go back to qualitative, so a little bit of a sandwich effect here. Okay, so immunization delivery is the topic of the project, and specifically in the OBGYN setting. So the problem is that not a lot of adults are getting the recommended vaccines. And in fact, when you look at women of childbearing age, about 30% consider their OBGYNs as their primary care doctor. But we know from a lot of research that OBGYNs have not typically provided a lot of vaccines, especially for patients that aren't pregnant. And sort of at the whole time that this idea of OBGYNs assuming a more PCP type of role was going on, there were also several new vaccine recommendations that were made specifically for pregnant women. So in 2004, influenza was specifically recommended for all pregnant women, and then recommendations for the tetanus, diphtheria, acellular pertussis vaccine, otherwise known as Tdap, had recommendations made in 2011 and 2012. So around the mid-2000s, there was a lot of activity and interest in trying to find ways to have OBGYNs do more of a larger role in immunization delivery. And in fact, the American College of Obstetrics and Gynecology, also known as ACOG, put forth 2 calls to action. So in 2011, they put forth an expectation, a position paper about how OBGYNs should function as PCPs, recognizing that a lot of women, this is really their main access into medical care. And then more recently, this was actually after our trial was completed, they actually had a statement about how OBGYNs should offer all ACIP recommended vaccines to patients. So not just the ones for pregnant patients, which obviously OBGYNs deal with that population a lot, but for all vaccines recommended for all adults. So that was a real shift in sort of the thinking about what constitutes the scope of an OBGYN's practice. And I should, at this point, just pause and give one caveat to this talk, which is that I didn't actually write the grant. I just got to be the PI on it. It was a really nice role for me. So Allison Kemp, who's here in the audience, she was the actual one who conceived of this grant, and then I took it over when I came here. So just putting that out there as full disclosure. Okay, so the research questions in the grant were, can OBGYNs improve their immunization delivery if we were able to provide them with education and assistance in implementing what we knew from a lot of prior research as evidence-based practices that could help improve immunization uptake. And most of these evidence-based practices, which I'll talk about in a moment, were got their evidence base in sort of the pediatric realm. There were some that were in adolescent and adults, but a lot of the evidence base was from pediatrics. And none of this work had ever been done in OBGYNs before. And then as sort of a subset to this broader research question, there were some sub-questions of whether or not this approach would work for pregnant women in OBGYNs, as well as non-pregnant women seen in OBGYN practices, and then whether there was specific practice characteristics that were associated with variation in the success of the intervention. So here are some evidence-based practices that were considered as part of the intervention for this trial. Reminder recall, that's where you have an office or sometimes a centralized agency like the health department send out a letter or a phone call telling somebody that they're either due for a vaccine coming up, like, hey, it's flu season, come and get your flu vaccine, or that they're overdue for a vaccine. Hey, you missed your last HPV shot, you should have gotten it 2 months ago, come in now to get it done. Increasing access to vaccines, so this can mean things like providing vaccines in alternative settings or in a after-hours clinic or in a clinic that is like a flu clinic where all you do is come in to get your flu vaccine and go. Standing orders for vaccination. So what these are is usually a written template, or sometimes it's an electronic format, that allows a mid-level provider like a nurse or a medical assistant to be able to assess for vaccination status and then actually sign for and deliver a vaccine without the physician having to be involved at all. So the physician kind of signs off on, yes, we're going to do standing orders for vaccination in our clinic, and it can take a lot of the work out of the physician's hands, and sometimes vaccines can even be delivered before the doctor gets in to see the patient. Assessment and feedback to providers. So this is like explaining to providers how bad or good they're doing in terms of their uptake among their patients with regard to vaccination, which can sometimes be a motivator for doing better. Family incentives, so this is essentially paying people in money or other types of incentives to get vaccinated. And then provider reminders, such as an electronic medical record alert or written reports, things like that. And then finally, combinations of these activities are also particularly effective. So these are some of the things that we know from the pediatric world are really effective at improving vaccine delivery, and some of the things that were considered for being tested in the OBGYN setting. So this project was a 3-year grant that was funded by the CDC. It was an R01 level grant, so a decent sized budget. And it was designed as a cluster randomized pragmatic trial that had 2 arms. So the first arm was implementation of a multimodal intervention, including one or more of those evidence-based practices, and I'll explain a little bit about how we decided what to do versus usual care. The geographic focus of the trial was in central Colorado. And at the time, there was really 3 vaccines that were targeted. This was, remember, before ACOG came out with the statement saying that OBGYN should be able to provide all recommended ACIP vaccines. At the time, the focus was more specifically on these 3 vaccines, which was Tdap, influenza, and then the human papillomavirus vaccine, or HPV. So as I mentioned, this was a 3-year project, and I'm going to go through these years and how they relate to the various methods in a moment. But basically, year 0 was a baseline qualitative assessment, and then intervention development and planning. Year 1 was starting the implementation of the actual evidence-based practices. Year 2 was implementing more of those evidence-based practices, doing our quantitative assessment of vaccination uptake, and then a qualitative assessment of what it was like as a practice in the trial. Okay, so now it's time to make the sandwich. So we're going to start with the first piece of bread, which was qualitative. So we did qualitative interviews, and these were used to inform the research team about what immunization activities were actually already ongoing in these practices. And this resulted in one end product that I'm going to describe in some detail called an immunization delivery scale. The second thing that we did in this first qualitative step was we did some fairly intensive intervention planning and came up with a second end product, which was a list of intervention components that we wanted to actually implement in our trial. So the qualitative interviews took place prior to randomization of the practices and included a couple people in the office who are most familiar with the immunization delivery process. So this might be a medical assistant or an administrator or some kind of like lead person in the clinic, usually not the physician. We developed an interview guide, and several people in this room were involved in actually doing these interviews. And the interviews were audio taped and transcribed. And we didn't really do a full-on formal qualitative analysis of our results because our goal was really just to try to describe current processes and activities that were going on in the clinics, not to do a full-on kind of standardized qualitative assessment. So we had 12 OBGYN practices, and they had been recruited to participate in this trial either as control or intervention, and 8 of them were in urban settings and 4 were in rural settings. And the interview guide addressed 7 questions that were sort of like practographics, so things about practice size and patient characteristics. And then 8 questions about vaccination operations that were currently being used. And we asked these 8 questions of each of those 3 vaccines that we were interested in, recognizing that offices might have different practices for different vaccines. So the things that we specifically asked about with prompts were which vaccines were being stocked or purchased for the practice, how they track patients' vaccination history, either vaccines that they got in the office or vaccines that they had received outside of the office, how they used their systems to identify patients that might be eligible at that visit for a vaccine, whether or not they used standing orders, and if so, for which vaccines, what type of patient education, if any, they had, how they assessed for missed opportunities. So a missed opportunity is a visit where a patient came in to be seen by a provider. They could have received a vaccine, like they were eligible, but for whatever reason they didn't. Oftentimes it's because a provider didn't actually assess their vaccination status, so it kind of never came up. And then whether or not they used any type of reminder or recall system. So here is what we did with some of the qualitative information. We created what I mentioned before was this immunization delivery scale. So I'll kind of walk you through this here. So these are 7 items that I mentioned we asked about specifically. And we had a quantitative way that we sort of assessed this. So we used our qualitative data that we had from the transcripts and assigned practices to these different scores depending on what level they were doing in terms of stocking vaccine. I'm not going to go through all of these, but just as an example, you would get a score of 0 if you didn't do anything. You got a score of 1 if you stocked the vaccine for certain patient populations like pregnant women, and you'd get a score of the 2 if you stocked vaccines for all eligible patients. And so we were able to use our qualitative data systematically to go through and convert it into this more quantitative product that helped us to kind of rank the practices against one another, and I'll tell you why we needed that information in a few slides. So here's just some brief results. You can see that everybody stocked the HPV vaccine, and there was a lot of variability in terms of the other vaccines, whether it was stocked for all patients or just for eligible patients. And then these are just some results, some sample results from the immunization delivery score. So remember, higher numbers are better, meaning more comprehensive immunization delivery techniques. And you can see that there was some variability between the various vaccines in the different types of activities that we were assessing. So this is the one for identifying patients, tracking their history and education. And then here's a similar diagram for use of standing orders, missed opportunities, and reminder recall. And just want to point out, like for some of these vaccines, there was absolutely no activity going on. So there was a lot of room for improvement. And then finally, you can see this is the composite score. with the scores from all practices together and also divided by urban versus rural. And essentially what you can see is there's not a huge difference between urban and rural, that a maximum score on the immunization delivery scale was 47 and the average was only 15. So again, this is telling us that using our qualitative data, we were able to say in a very quantitative way that this is, that there's not a lot of immunization stuff going on at these practices. The second end product was trying to decide on what specific intervention components we wanted to try to implement in this trial. And this really involved a lot of delving in the qualitative interviews of understanding the current state of immunization delivery in each practice and for each vaccine, and then trying to use that information to plan for the specific components to implement. And from this, we ended up coming up with a list of several intervention components that we wanted to try to implement in all practices as a minimum kind of intervention. So the first one was to agree to stock all 3 vaccines, because not all of the practices were doing that, but several of them were. Have the practices agree to implement at least 1 new standing order for vaccines. So some practices had a standing order for 1 vaccine or 2 in place already, some had none. We wanted everybody to do at least 1 and have it be a new one. We also wanted all providers and staff in the intervention practices to receive education on best practices in immunization delivery, and this was kind of twofold. We had a provider education piece where we had somebody from the health department come in and go over the evidence-based practices that I mentioned already. And then we also had, we made available somebody who was a senior administrator at a very successful primary care pediatrics practice who had a lot of experience in actually optimizing immunization purchasing and billing. And he came in and worked with the OBGYN administrators in those practices to try to help them optimize and streamline their ordering and billing for their vaccines. And then finally, designating within each of the intervention practices an immunization champion who could help spearhead the intervention that we were doing, and eventually ended up meeting about twice a month with the study team throughout the intervention. We also made a list of several alternative or additional intervention components that could be potentially implemented in the practices. And these were really based on the practice's readiness. What were they doing already? So we obviously wanted them to achieve the minimum set of standardized practices, but if they were already close to that, we wanted to give them an opportunity to improve even further. And so we had a list of these 7 additional activities that they could do that are all evidence-based. Okay, so to summarize our first piece of bread, practices overall weren't doing very much with regard to immunization delivery. There was a lot of variability among the practices and by vaccines. There seemed to be a set of interventions from our qualitative work that would be feasible to implement in all of the practices based on the current state of these practices that had agreed to be in the trial. And depending on the practice and their readiness, some might actually be able to implement other interventions beyond the basic components. Okay, any questions about that part before I move on to the peanut butter? Okay, all right, so now we're going to talk about the quantitative piece. So this had several steps. The first step was to randomize, and I'll talk about how we used our qualitative data in the randomization process to plan the specific study activities that we were going to do, to actually implement phase 1 of the project, which was that list of minimum interventions. And then the second year of the intervention part was implementing the other phases and then assessing vaccination status. So our randomization was something that we used a method called Covariate constrained randomization. And this is a method that's actually recommended for use in cluster randomized trials such as this one. So what ends up happening in a trial like this is because we only had 12 practices, that means you only have 12 clusters, which doesn't give you a lot of statistical power. So even though you're randomizing, there are certain practice characteristics that could really influence your outcome. For example, the proportion of OB versus GYN patients, or the proportion of patients who are on public health insurance versus private. And so what covariate constrained randomization does is actually a statistical process that allows you to pick out a few variables that you think are really key for potentially affecting your outcome that you're interested in, and allows you to balance them across arms in a way that's fairly random and doesn't introduce bias into your randomization. So we actually used a lot of our qualitative data in the covariate constrained randomization process. So these are the variables that we used in the covariate constrained randomization algorithm. The number of providers that were providing care in the clinics, which we got from the qualitative, the number of deliveries per month, which was also obtained from qualitative data, the percent of public insurance, which I think we got that from a more quantitative source like the electronic medical record, and then the immunization delivery score, which was, as I described, that very quantitative version of things that were completely informed by our qualitative data. And so here's the results of our covariate constrained randomization. And the main thing to point out here is that when you look at the p-values between the intervention and the control arms across these 4 different categories, you can see that there's no statistically significant difference between the two, showing that we have balance across, the 6 and 6 practices in control and intervention are relatively balanced in aggregate when you look at these 4 variables. Okay, the other thing that we did was we did a lot of planning with the practices, and we used something called process mapping. Who here is familiar with process mapping? Okay, lots and lots of people. So this is kind of what they look like. This is only a snapshot of the upper half of one, and I'll just point out kind of what we did. So these are all the steps involved in getting a vaccine into a woman's arm in an OBGYN setting. And it's divided into different swim lanes. So patient lane, the front desk lane, the medical assistant or nurse, and then the provider. And then you can see that there are multiple steps here that have lots of arrows going all directions. So an example of what was going on in the OBGYN looks like this. This was a current state process map. This was, again, informed by some qualitative work that we did, and it showed all the different steps. I think Julie's probably having PTSD at this point, like, oh my God, I remember doing this. And this is what we were trying to work with practices to get them to the future state, which you can see is much more simplified. It doesn't really matter what the boxes say. You can just see that there's a lot fewer arrows and a lot less boxes. And so by doing this very kind of rigorous and somewhat quantitative process, we thought that we might be able to really shift the way that these practices were delivering vaccines. Okay, so as our third step, we implemented phase 1, which were these 4 different activities that we said were required of everybody. And then as our 4th step, which was the beginning of year 2, some practices were able to implement some of these other activities, but not all. Okay, so now I'm going to tell you about the quantitative outcomes very briefly. So again, 3 vaccines on the left that we assessed, the different populations. So basically the only thing to know here is that we don't assess HPV vaccination in pregnant women because it's not they're not supposed to be getting it. It's contraindicated during pregnancy. So here are the methods that we used. So we did an analysis, a quantitative analysis of all patients seen at the intervention practices during the study period between the ages of 15 to 100. So pretty comprehensive. I don't think we had any 100-year-olds, but there might have been a few in there. And we use administrative data that we obtained directly from the practices. So we basically pulled the data out of their EMR. And our analyses were stratified by pregnancy status because obviously the vaccines that people are giving are different depending on if you're pregnant or not. And also the prioritization of how important some of these providers thought it was to vaccinate vary depending on pregnancy status. We used the administrative data to define an OB patient as somebody who had had at least 1 OB visit during that year. And some patients, because this was a multi-year study, could be OB patients in 1 year and GYN patients in another year. We also had a mixed category of people who seemed to have both OB and GYN care. The statistics we use are completely beyond me, but I'm assured that they're completely legitimate, but it's called multi-level log binomial regression models, which I couldn't tell you much about. But basically what these do is they allow for clustering at both the patient level and the practice level. So this obviously is important to cluster at the practice level because it was a practice-based intervention, but it's also important to cluster at the patient level because for some of these vaccines, vaccination could happen multiple times, for example, HPV, or you could also imagine like if a person is generally vaccine accepting, they might be more likely to get all the vaccines that they're recommended as opposed to someone who's generally not vaccine accepting, they might not want to get any vaccines. And then really the key here is that the analysis that we did is the difference in difference analysis. So we know that over time, vaccine practices are likely to change and usually vaccination improves over time. But what we're really interested in is looking at improvements in control versus improvements in intervention clinics to see if there was more improvement in the interventions than in the control practices. And all of the models that I'm going to show you in the next few slides were adjusted for whether or not they were a rural or urban practice, the insurance type of the patient, and the patient's age. So a little side note, before we get into the results, I want to talk a little bit about the scope. And this is my little soapbox about what it means to be a pragmatic trial. So I saw a talk once several years ago by a very well-respected pediatric researcher, and she was talking about her pragmatic trial. And she said, by pragmatic, I mean messy. And that's, I think, a really good way to put it. So I'll give you an example. So we actually had 13 practices when we started. I was kind of lying when I said we had 12. We had 13 practices that were initially recruited, but 2 withdrew after we randomized. And it ended up that because we had a big imbalance in rural versus urban, we had to shift one of the control practices into an intervention practice so that we could have balance again between rural and urban. So that was kind of a mess. And then the intervention started, and then one practice folded. It closed. So that sucked because we'd spent a lot of time with them. And then we had another practice that kind of started, and then their parent organization and said, you know what, we don't actually want you to participate in this trial. We're not willing to share our data, so you need to stop. So they dropped out. And then we finished the intervention, and then we had one practice at the end who we could not pull out their EMR data despite many, many, many attempts and a lot of money. So in the end, we actually had 8 practices that we analyzed for our trial, 4 interventions and 4 controls. So luckily, at least they came out balanced. So that just gives you a sense of what it's like to do pragmatic trials. Okay, so to orient you to this slide, this line down the middle here is basically the 0 line. So any confidence intervals that cross 0 are nonspecific. And this is the results for TDAP, intervention and control, and then intervention versus control. So what you can see is that in OB patients, intervention practices improved over time, control practices improved over time, but there wasn't a statistically significant difference in the improvements between interventions and controls. And then the same result occurred for Tdap vaccination in the non-OB patients. Similarly, we found no difference when you compare intervention to control in influenza vaccination for OB or non-OB patients. And similarly, we found no difference between interventions and controls for HPV vaccination in gynecology patients. So it's a big, fat, negative trial. Woo!
And it was a sample size issue?
No. We had thousands and thousands of patients. No, I think it was just a difficulty of changing practice behavior issue. So some overarching conclusions from our quantitative analysis. Obviously, I've simplified this quite a bit. There was a lot more to the trial than what I'm showing, but hopefully I've conveyed that pragmatic trials are difficult, sometimes painful, and despite our best efforts, and we did a lot of hand-holding with these practices, our intervention didn't work. So that was actually very useful because we kind of felt like, gosh, if our intervention didn't work, then many other things are not likely to work because we were in their offices a lot trying to help them to get this done. Okay, so now I'm going to turn to the final piece of bread, the last qualitative piece. And these were qualitative interviews that we did to understand the barriers and the facilitators. And kind of, we didn't actually know for sure that our trial didn't work until much later after the qualitative interviews had been completed, but we had some inklings just based on sort of initial looks at the data. So we didn't spend as much time, I think, understanding in our qualitative interviews why it didn't work, but we focused on sort of general barriers and facilitators to the intervention components. And then the idea had been like, oh, this is going to be a great trial. We're going to use this to plan for our next steps. Like, where can we optimize this? How can we do better? What's the next place to sort of target this? And this was, of course, before we knew that this was largely negative trial. So I'm going to just add a quick caveat here, which is that when you're doing mixed methods research, ideally you want to make a club sandwich than just a regular sandwich. So you have your qualitative, your quantitative, you do a little qualitative in between, kind of figure out where you're at, then maybe refine things and do some more quantitative, and finally wrap up and do your qualitative at the end. But based on our timeline and our budget, that isn't what we were able to do. So these qualitative interviews were 39 participants at the intervention practices, and we actually were able to interview most of them over multiple years, kind of as we were going to sort of understand how things evolved. And our focus was largely on the implementation of standing orders. Did they reach their goals in terms of the number of standing orders that they wanted to implement? And then we also looked at barriers and facilitators of all the other intervention components as well. So overall, the results were that only 2 practices met their goals for implementing the standing orders for all the vaccines. No practice was successful in implementing all the planned activities, which is probably why we ended up with a negative trial, because this was so difficult for them. And one of the biggest barriers was that it was really difficult for these practices to establish operating procedures that would help facilitate the project activities. And a lot of this had to do with competing demands based on nurses and MA time. So this just didn't rise to the priority level that it needed to be in order to allocate the necessary resources to make this successful, even though we were doing a lot of the work ourselves on the study team. And an interesting thing that I guess makes sense, it's kind of a duh moment, but it was helpful to actually see data on this, is that in terms of the standing order piece, pregnant women actually didn't really like the standing orders. They wanted to be able to talk to their doctor directly and make sure that it was okay for them to get vaccinated while they were pregnant. Probably nowadays, now that pregnancy and vaccination is more of a widely practiced thing, this might not be as much of a barrier, but at the time that this study was going on, it was relatively new, and so this was something that we didn't necessarily anticipate. Okay, so our conclusions from this is that even with a ton of hand-holding, and I mean a ton, like we were out there all the time, there was really a lot of barriers to these practices implementing the evidence-based interventions to improve vaccination. And it was difficult for them to do this for all patients, but there were some unique barriers specifically for pregnant patients. And one of the biggest factors about this was the competing time demands and the need to establish new office procedures that were just completely different from what they had done in the past. So putting this all together, I really feel like this sandwich approach of the qualitative, quantitative, and qualitative is really useful for both planning these pragmatic trials as well as conducting them. And then if you have a successful trial, so we've used this model for other projects that I didn't talk about today, because I was told I needed to talk about the OBGYN trial, and I was like, don't you want a trial that's actually worked? Well, that's okay. I could get up here and tell you about my negative trial, it's fine. But I think, the planning stage for things that are successful, or even things that are only partially successful, the qualitative piece at the end is really key, because it can really help you understand why certain things worked and others didn't, and how to maybe make those things that didn't work better or more likely to work in the future. So, we use this qualitative to design and refine the intervention, a quantitative sort of for the main clinical trial, and then again, a qualitative piece for assessing sort of barriers and facilitators. So some of the lessons that we learned from this work is don't skip on the qualitative parts. They're really, really helpful, especially the work that we did at the beginning. Even though our trial was not successful in terms of changing immunization rates, the actual processes that we implemented went relatively smoothly, and a lot of that was related to the fact that we did so much qualitative work up front in terms of planning with the practices and understanding kind of where they were starting, that I think we did a good job trying to kind of meet them where they're at and take them to the next step, whatever that might be for that particular practice. The qualitative work at the beginning can really help you plan your quantitative analyses. So we definitely uncovered some things during our qualitative interviews at the beginning that helped us figure out, we need to, assess pregnant and non-pregnant women separately, because offices have really different practices for both of these populations. Like, they might have a totally different day when they see pregnant women versus non-pregnant women, or totally different staff who see the pregnant women versus the non-pregnant women. And so that was really helpful in trying to figure out how we needed to design our quantitative analyses. And then, I would recommend that as you're conducting the quantitative portion, you actually use that information to consider what new qualitative issues you might want to address later. So for example, had we known really early on that our trial wasn't going to be successful in terms of improving vaccination delivery, we would probably have added in some questions specifically saying, like, what more did we need to do to make this successful? Why do you think it didn't work? So you can really use both of them to inform each other. And then, of course, if you have time and money, consider making a club sandwich rather than just a plain old peanut butter one. So that's all I have for you guys today. We have lots of time for questions. Anybody wants the recipe for this, I can try to give it to you. Yes.
Well, I just wanted to say that I feel your pain. I just finished conducting a very large negative trial. And we actually had the qualitative component that was supposed to be later, but we moved it up after we got those results.
Yeah.
And did a very rapid assessment, qualitative assessment from all the practices about what they think could have interfered.
Yeah.
And we're able then to have that form another iteration of the trial.
Oh, you made the club sandwich.
We kind of did.
Yeah.
And we actually changed in the middle because we. The other thing I wanted to ask you was how important and how functional were your champions?
That's so long ago. It's really hard. This was like digging back through the memory trunks trying to put this together. Yeah, I think they were pretty involved. I mean, we had people out there in person meeting with them twice a month. So it was kind of hard, it's kind of hard to tell somebody face to face, like, I'm going to do this and then not go do it. And then 2 weeks later, they're back and saying, did you do this? Why did you do it? Why didn't you do it? So I think, obviously there was variability, but I think that I think they put forth a pretty good effort. We paid our immunization champions a little bit. So, that was also motivating, but I think also that in-person relationship that they had over the 2 years of the implementation phase really helped to get their buy-in. I don't know, Sarah and Julie, you might have more.
Yeah, I think the other thing that really engaged them was that we did that sort of technical assistance troubleshooting with them at each of our meetings. Okay, let's try this. Okay, that's not working for your standing order. Let's try another approach. And so really being able to work with them, that this intervention we chose, but how we make that happen is really dependent on the practice. And so they had support in this throughout that process.
Mm-hmm. Yeah, Ethan.
So you mentioned that after your first piece of bread, you came up with a set of minimum intervention strategies that you wanted the practices to do.
Mm-hmm.
How did you decide that? And in your data analysis, did they do the minimum, just not everything you wanted them to do? Was there an effect at that level?
Mm-hmm.
So 2 questions there.
Yeah. So the way we decided is we tried to figure out, it was fairly just sort of random. So we tried to think about what were the evidence-based practices out there. Some are much more difficult to implement than others. For example, standing orders is literally a piece of paper that everybody agrees they're going to adhere to. Reminder recall is like a whole thing that requires a lot of personnel time. So we chose based on feasibility, was probably the biggest driving factor, and then kind of what we thought practices could reasonably do based on where they were. So everybody was doing a little bit of something. So we tried to think of collectively as a group of practices, what would be reasonable to expect that everybody could get to. So maybe some people already had standing orders, so implementing a second one might not be such a big deal, but tracking vaccination status, which is something they hadn't done before, would be a big lift for them. Whereas in another practice, it might be just the opposite. They are already tracking their vaccination status, but they don't have any standing orders. So they're already doing one of the components, but we're asking them to now add this other thing. So we kind of tried to look at what seemed reasonable to do within our first year. The second question about did anybody get to all of their, do we look at it that way of who attained the minimum practices? I don't know if Sean, do you know if we did that?
We did end up rescoring.
Yeah, I can't remember either. It definitely wasn't a main outcome that we looked at. Vaccination uptake was the main one. Spent a lot of time trying to figure out how to assess that. But it would be interesting to look at. The problem was every practice kind of had a different set of things that they wanted to do. Some were very ambitious, some weren't so much. Dennis, go ahead.
And either of your peers, you guys
Well, I think, from what I recall, this is 5 years ago now, but from what I recall, I had to go back and read the papers. I think we asked about policies, how these ACOG policies and these new immunization policies impacted kind of how they made immunization a priority or not. And, during the time of the trial, there was actually a couple changes in the vaccination records. So we talked about that a little bit. Do you guys remember what else?
The one other that comes to mind is we did, I don't know that we specifically asked about it, but it ended up coming up through our immunization champion meetings, which then fed into our second set of qualitative, was around billing and reimbursement. And
Oh, that's right.
whether they really focused on particular vaccines based on whether or not they need to get reimbursement from particular kinds of insurers.
Mhm.
Actually spent a lot of time working with the state then to inform review practices about the fact that they reimbursed for Tdap, for example.
Right, that's
because
right.
we had a number of practices who weren't offering Tdap to Medicaid patients because they thought they wouldn't get reimbursed.
Mhm. And that had to do with it being a new recommendation, so they just hadn't done it before. Julie?
I think another thing that I just remembered that was kind of interesting to me about the training and that several of the OB-GYN providers said, I'm a specialist, I'm not running care. It's not really my role to be vaccinated. This population is supposed to be going through care. So that was in play too, with kind of their training and
Their thought, yeah.
who am I, what is my job?
Yeah.
That came and had some practice as well for some individuals, not all.
Mhm. Yeah, I think that had to do with like how they prioritized vaccination over other things that they did in their practice. Yeah, Patrick.
You mentioned, your outcome as the implementation of these new methods of reminding patients. Did you do a separate analysis of how often that actually resulted in a vaccine? I mean, with standing orders, is it basically 100% if you intervene?
Yeah, we were not able to do that. A lot of these processes that were implemented were not electronic, so tracking them is nearly impossible. Like tracking standing orders would be really difficult. You'd have to go through the chart and find those pieces of paper and see how many were signed or had notes on them or whatever. So
did the qualitative analysis reveal much of if they actually did the interventions, did they have problems?
yes, that for sure. So, I mean, there was some practices that, quote, did the intervention, but they didn't really do it that well. A big one that was difficult was tracking immunization status, because there is data that maybe comes in from your electronic medical record about a vaccine that you gave, but then maybe you also need to somehow track, did a flu vaccine get given at Walgreens? And so, some practices would say, yeah, we're tracking, but they weren't really tracking in a way that was actually useful. Like they might only capture the vaccines that were given in practice and didn't have a systematic way that we could at least see in their EMR where we could track other vaccines that were given. You guys probably have other examples. Yeah, we did. I didn't talk about that, but
That was one thing we did. We were able to show that, at least to an extent, they improved their immunizations, not perfectly, but better. So, another
Yeah.
data point.
mm-hmm. Yeah. Any other questions?
Mandy, this is Chris. Still, I'm on the phone.
Hi, Chris.
Oh, wow, I can hear myself like with a 1 second delay. Thanks so much. This was really helpful. It helped me think about how we should write up the results of our negative R40 trial that we're finally getting to writing the paper. What the question that I had is, how surprised were you when you got to sort of the results and comparing that to the qualitative data you did after the second piece of bread, or weren't you surprised? Was it pretty much what you expected?
I think we were all a little surprised that it was a negative trial because we had been in those offices so much. And I think from what I remember, the practices actually felt like they were doing a really good job. They felt like they had done a lot to change. And so the fact that we didn't actually see meaningful improvements compared to our control practices, from what I remember, was kind of surprising. Just based on sort of their own self-assessment that we got through the qualitative interviews about, oh, this is great, and we're doing all this stuff now, and now we can track, and we have these standing orders, but it didn't seem to really matter. And I think that probably gets back to a lot of variability in how stringently those, quote, new practices were systematically implemented.
Yeah. Yeah, it's so frustrating because you do all this qualitative work ahead of time to make the perfect intervention that you think will resonate perfectly with everybody, and it's never exactly what you think it's going to be.
Yeah. Ain't that the truth? Yeah, Megan.
Do you have a sense whether or not people have any questions
I don't think we ever looked at that. We were all kind of done with each other by the end. They were so sick of us, and I think we offered at the end to go back and like kind of present the results. And from what I was looking at an old Beyond. Yeah, nobody wanted us to come back.
Oh, that's okay.
Bye.
Yeah. We were definitely trying to push them to do something that they had not done in the past. So.
In this case, it is kind of what Mandy said. A lot of you had some people who really didn't believe they should be doing it in the first place, and then you had other people who believed in it, but they were just too busy to really make much of it.
Yeah, it was very hard to feel like really anything got implemented universally across any of the practices.
And the other interesting thing just to think about from a pragmatic trial generalizability standpoint is these are practices that agree to participate in this immunization project because they were probably somewhat more enthusiastic about immunizations than average practice. And I can't even tell you how many doors we banged on these practices. And so who knows what's going on in the rest of the
Yeah, that's why I was saying, like, we kind of felt like with the amount of hand-holding that we did and with that bias about probably more interested people participating, we still didn't find anything. It was just, I think it's hard needle to move.
Well, and I think that in response to the were we surprised question, I was surprised at how much some of the control practices
Improved, yeah.
on some of these vaccines.
Yeah.
Given the amount of hand-holding we did and the amount of work that was put into really put these processes in place.
Yeah.
Have practices who didn't have that hand-holding also make improvements was I think where my surprise really came in.
Yeah, that's a good way to put it.
It seems like the controls cost you your significance on TDAP. They had a pretty good improvement.
Mm-hmm. Yeah.
Did any of your control practices implement strategies on that?
Not really. I mean, I think we asked about that at some point in the study immunization meetings, and there was nothing really major. Maybe a little bit here and there, but.
I think scores one up there too, which means they were adopting some of them.
Yeah.
And keep in mind that there was a change in TDAP recommendation through the period of the end. This is really hard to figure right out because the recommendation for TDAP changed twice during the study period. And so it went from being recommended once in pregnancy and never had it before to being recommended every pregnancy. And so that was changed the environment and studying.
Mm-hmm.
So
Fun times.
So, Mandy, you mentioned that reminder recall is that it's really intensive, but maybe also the most effective.
Mm-hmm.
Do you think maybe practices that really, where this is a priority, that they could go above and beyond and do that in order for it to be effective?
Well, I'll let Allie answer that because she has a lot more insight.
Say, reminder recall is very effective, but not universally. I think it's quite different for different vaccines and different populations. That's what we're finding out. So my guess is that in this population where you've got a lot of, well, certainly the pregnant population, it's probably a lot more dependent on the provider giving a strong endorsement. So I wouldn't say we would know if this would work in this population. We just did a large, bigger trial of flu reminder recall, even though centralized reminder recall is extremely effective for childhood immunizations. It looks like in 2 states it was ineffective. Flu is a very different vaccine.
The other thing too is, OB patients are coming into the doctor a lot. So there's a lot of opportunities to actually remember to vaccinate them while they're in the clinic. And a lot of times reminder recalls, I think, would be potentially more effective for people who might not be coming to the clinic at all, or they only come very infrequently and miss like the time window when they're supposed to get the vaccine because they came in too early. And now it's like a year later and they're not thinking about coming in, but they need to. So that also plays a role into it as well.
I think, in this one specifically, all the practices, intervention and control prioritize immunizing pregnant patients.
Right.
And I think they actually, because they come back so frequently, it's actually not that hard to get pretty high rates.
Yeah.
Unless people refuse.
Refuse, yeah.
And so I think we saw that with Tdap in the pregnant population. In the non-pregnant population, even though the practices had agreed, they said, oh yeah, we would like to expand our immunization to the non-pregnant population. They didn't do it at all. And so even though they had sort of said that initially when we recruited them, they didn't want to do that. And so that was another sort of finding from this study is that vaccination non-pregnant patients is not a priority. And then the other thing I think, that back to the reminder recall question, that kind of speaks to the larger issue. These were evidence-based practices that were found to be evidence-based in certain settings, pediatrics and medicine. We were trying to adapt them to the OB/GYN setting, but one of the major lessons that sort of speaks to other pragmatic trials as well, evidence-based in one place doesn't necessarily ring true in another, because there's different patient flow, settings, et cetera. So it may be that even in the best circumstances where they actually do implement all of these things, they don't work.
Yeah.
As a pediatrician, I can tell you that immunizations and things are really take a lot of effort. It takes somebody who really knows how to give immunizations. And reimbursement is key. If you're not being reimbursed, these are expensive.
Yeah.
And if you're not being reimbursed for your personnel's time, it stops.
Yeah.
And you don't have anything like vaccines for children.
Right. Yeah, that was one of the reasons why we had the 2 meetings with the pediatric practice administrator, because it became obvious pretty early on that like these practices didn't really know how to do this very effectively. And obviously, if you're losing money on this, then it's kind of something that's not going to be a priority. Those meetings I think were helpful, but I remember afterwards, the facilitator was saying like, they're not doing these things. Like there's all these things they need to be doing and they're not doing them. And you can imagine, vaccines are such a huge part of pediatric practice and it's evolved over decades that the systems can really be optimized now. But for an OB/GYN practice, it's starting this sort of really systematically as a new thing. It's a lot of stuff to take on at once.
And then you almost need a separate insurance.
Yeah. Yep.
For them too, though, it's such a small
Part of their
overall financial pie. In a pediatric office, it's more than half, right? In an OB practice, it's a sliver. And so they actually, when the administrator went with them, a few of them, he kind of came back and said they didn't really even want to borrow money. Like they practically didn't care.
Yeah.
Because it wasn't, in the grand scheme of their finances, it didn't make that.
Right, compared to like some kind of surgical procedure that they might do.
We went in with that preconception that they needed this. This was going to be a really important thing for their program, but
Yeah.
it wasn't. They didn't find it useful. It was really interesting.
Yeah. All right. Well, thank you guys all for coming.
In your evaluation, Brian there in the corner.
You're in the corner. You didn't sign in anyway. Please sign in.
Yeah, that was really good. It's really good. Sally's there. Good idea.
Yeah, we'll see.
Thanks for inviting me.